introduce Dr. Matthew Weir, who's a professor of medicine at the University of Maryland. And he's going to talk about a very important topic, not only for dialysis patients, but for CKD, especially with the evidence that MRAs and ACE inhibitors are very, very helpful in CKD and heart failure. He's going to talk about treatment of hyperkalemia. So Matthew, thank you very much for agreeing to come.
Thanks very much, John. It's a pleasure to be here. I'd just like to let everybody know that since you are in the prandial state, your serum potassium is actually going up as we speak. But hopefully it won't go up too much, depending on what you're taking. So what I'd like to speak about today are some practical issues about the management of chronic hyperkalemia. I'll be focusing primarily in folks who are not on dialysis, but you know, a lot of this can be also addressed for the dialysis patient as well. So I don't want to forget about them, since that's the whole purpose of our course. Here are my disclosure slides. I'd like to point out among the advisors I work as is for Relipsa, which is actually the manufacturer of Potassium, and this is the same company that made an educational grant for this conference. So just want to make sure that disclosure is all out there. All right. So the mainstay of therapy, as we all know for our patients, is to block the renin-angiotensin system. This is the only proven therapeutic strategy for people with established cardiovascular and kidney disease that we have today to slow progression. And again, it provides about a 20% relative risk reduction benefit. There are many different ways that we can block it, with ACE inhibitors, angiotensin receptor blockers, and perhaps, most important, the mineralocorticoid receptor antagonists. And this is an area that there's going to be a lot more work, especially in people with chronic kidney disease, and even in patients on chronic hemodialysis, as there is more and more interest about the potential opportunities to retard cardiovascular disease progression and vascular disease with MRA. So I think there's going to be a lot more interest in targeting this system. But of course, the linchpin problem that we face with all of these therapies is hyperkalemia, despite what you see here. Now, of course, we've also learned that using ACE and ARB together, or renin inhibitor with ACE or ARB, is not providing any incremental cardiovascular risk reduction advantage, but obviously more problems with potassium, so clearly that is not something we should be doing. But a few thoughts just to consider for us to spread the gospel, so to speak, amongst our colleagues. First of all, the higher the creatinine, the greater the risk reduction benefit with drugs that block the renin-angiotensin system. So again, we tend to lose sight of that despite our paranoia about sudden hyperkalemic death in our patients. And perhaps most important, really, global cardiovascular risk reduction efforts are necessary in all of our CKD patients, in large part because they have so much more risk. And so obviously we need to address that issue in each and every patient. So that being said, I still think the new frontier will be with the mineralocorticoid receptor blockers on top of ACE, ARB, beta blocker, whatever your choice is. This has certainly been shown to be the case in people with systolic heart failure. There's even the suggestion in U.S. patients in people with preserved ejection fraction they can be beneficial. And of course, we know long-term in our dialysis patients, it is heart failure and arrhythmia that leads to the majority of the deaths, not classic atherosclerotic cardiovascular disease as it occurs in the general population. So putting it into perspective, though, on one hand, you can see the outcome, the risk reduction benefits in the third column, but in the fourth column, you have to temper the enthusiasm with, obviously, the concerns you see listed there. And, of course, the major concern for all of us in practice is litigation, right, from our attorney friends if anything might happen to one of our patients. And I think in large part this explains why hyperkalemia contributes to ED visits, hospitalizations, and healthcare costs. despite the fact, as we know, that very rarely do these patients have any associated symptoms or side effects. But you can see how astronomical the numbers are, and we all know this from clinical practice. We also are aware of the epidemiology, and as you can see here, depending on age and comorbidity, as you move away from that 3.5 to 5 range, both low and high, I might point out, there is greater overall mortality. Now, whether it is the potassium itself or whether this is a marker for other medical comorbidity or cardiovascular morbidity is hard to say. But nonetheless, it is this type of epidemiology that scares us quite consistently in clinical practice. And I think we can all agree it is rare that anybody has a normal EKG who fits into this situation. Everybody's going to have peak T waves, whether or not they really are peak Ts related to the higher serum potassium level. But nonetheless, we run scared. Hyperkalemia is the leading reason for not using RAS blockers in our patients. It's the leading reason for stopping RAS blockers in our patients. There is abundant literature showing this, as you can see here. More importantly, if you look on the next slide, we can see here, we, the brethren, are low RAS prescribers, believe it or not. We, the brethren, are the ones who recommend stopping RAS blockers when people come with hyperkalemia and we're consulted. And this is obviously a concern. We both underdose and we underuse. And if you look at the data in people with established diabetic nephropathy, only 40% of people are even on RAS blockers who are seeing nephrologists. And of those 40%, only 40% are actually receiving a RAS blocker in a dose that's been established to be renal protective, which means that about 16% of people are receiving the only known therapy we have for protecting kidney function. So it's sobering. We obviously need more understanding and obviously better long-term treatment strategies. And I might add that litigation remains the major concern. I'll give you an example. I love this graphic. On the vertical axis is the serum potassium. On the horizontal axis are the various global guideline recommendations. Now, if you look in your upper right, these are the nice guidelines from the UK. You can't get sued in the UK if you're, NHS patients can't sue. And you will notice that in the NHS guidelines, don't stop anything unless the potassium's over 6. On the other hand, if you move down to your lower left to the EU, where there is more litigation, you will see now we're down to 5.5. And if you move to medical malpractice haven, meaning the United States, you will now notice it's 5.0. So appreciate that we tend to prescribe not according to guidelines, but according to likelihood of litigation. But again, we have to appreciate the epidemiology. We can joke about the lawyers and their interest in the serum potassium, but nonetheless, we do have epidemiology to say that higher serum potassium levels in older and more comorbid patients tend to have dire consequences. Which is why I think we need a brief review about potassium homeostasis and regulation. And again, I'd like you to appreciate that your serum potassium is probably going to rise 0.3 to 0.4 right now from whatever the baseline was. And the reason I say that, quite importantly, is dietary potassium results in a rise in serum potassium. And so when you measure the serum potassium, in fact, has a very important relationship to when the patient last ate, because fasting potassium levels are much lower than postprandial potassium levels, quite obviously. And so you need to always be careful about that in interpreting the various measures you get. But please appreciate that after you eat, the potassium goes up. It results in a release of catecholamines, insulin. Obviously, higher serum potassium increases aldosterone, and this obviously has impacts within the body to facilitate not only the transcellular distribution of potassium, but also facilitates renal and even colonic excretion. And that's how you maintain the status quo. You can remember that obviously the majority of potassium lives within cells. Only 2% is extracellular. This comes from a very nice review published last year in the New England Journal, which looks at where potassium is stored and how it is regulated based on timing of meals. And there's even a diurnal variation, which in fact is in part related to counter-regulatory hormones. But the liver is a very substantial storage place, as is skeletal muscle. And obviously, in the postprandial state, there is a release of potassium into the bloodstream, which obviously needs to be very carefully tempered throughout the body in order to maintain homeostasis. And obviously, if there are any clinical factors which may interfere with that, it can obviously lead to an elevation in serum potassium. I'll spend more time on this in a little bit, but I'd encourage you to read this review. It's really quite nice and practical from this standpoint. So remember, it is the nephron and the gastrointestinal tract where the majority of the absorption and secretion occurs. Again, appreciate as kidney function declines, the colon takes on a much more responsive element. Again, it is theorized that in people with advanced kidney disease, that colonic excretion of potassium can be as much as even 30% or more. Hence the need for maintaining regular bowel movements and why some people with constipation can run into problems with potassium excretion if they have advanced renal disease. There's also a lot of interest now that potassium exposure, whether through intravenous or through the GI tract, can have very different effects on serum potassium. It is felt that there may be gut relationships which may be important through gut hormones in regulating potassium homeostasis. There's also more and more interest that skin storage sites of sodium, which we're now learning may be important in terms of blood pressure, may also interact with potassium and may be important as well. A lot more research is being done to study this now. The etiologies of hyperkalemia are substantial. There are quite a few. I think first we need to rule out pseudo-hyperkalemia, which is very frequently the case. Again, sometimes just leaving the blood sit for more than 30-40 minutes may in fact lead to greater releases of potassium. In clinical trials of people with chronic kidney disease on RAS inhibitors, about 1/3 of the hyperkalemic measurements, when repeated, are within the normal limits, which shows you how substantial the repeat error rate is and why it's important to recheck whenever you get an elevated level that doesn't make sense. There are many etiologies. Here are some of the true ones, including redistribution. Acidosis and hypertonicity are quite important to remember, as is insulin deficiency. I'll spend a lot more time on the drugs. I've already touched on the RAS inhibitors and the MRA, but remember depolarization agents used for induction of surgery can also be important, as are beta blockers and cardiac glycosides. We in the nephrology field are obviously sensitive to the fact that advanced renal failure, typically GFRs in the stage 5 range, are much more likely to be associated with retention of potassium. Also, Addison's disease, and of course, some other drugs that we haven't mentioned yet, most notorious of which are the nonsteroidal anti-inflammatory drugs. Anytime a patient presents with a high K, that should be question number one. Of course, we also have the calcineurin inhibitors and even heparin. Pentamidine, often used in transplant patients as well. And there can be inherent renal tubular defects. I don't have time to go into all of these. And of course, there is also endogenous input and reduction in exogenous output, which can be a factor as well. I'd like to focus briefly on the issue of impaired extrarenal buffering. I think we need to remember this. First, note the big difference of intracellular to extracellular. It's about a 35-fold difference. The sodium-potassium ATPase is the most important regulator, which again, as you can see, can be impacted upon by a variety of hormones. We also know, if you look on the right, acidosis, hyperosmolality, cellular injury can also lead to important shifts. And of course, the medications come into play as well, and I've already touched on these. So when you look at a diabetic patient with chronic kidney disease, they have many reasons for hyperkalemia. I don't need to elaborate on this for this group. Likewise, in people with systolic heart failure, many of which who also have reduced GFR, there are many reasons for hyperkalemia. And sadly, these are the two main groups who benefit the most from renin-angiotensin system blockade and obviously MRA blockade as well, which can further aggravate the situation. Well, let me now turn my attention to treatment options. I'll start with the acute, although that's not really the main focus of my presentation today. I'd really like to spend more time on chronic treatment strategies. If you look here, the acute management is largely related to initially facilitating transcellular shift and altering the cardiac membrane to limit depolarization. And you can do this with glucose, insulin, and calcium. I think it's important to realize that emergent interventions will always require some form of intravenous therapy, followed up by some form of definitive therapy. Definitive therapies in dialysis patients would be obviously hemodialysis. In people with advanced kidney disease, hopefully not dialysis, but certainly large doses of saline and Lasix. Sodium bicarbonate can also be added and can be utilized in this regard. A lot of people tend to forget that the major problem with hyperkalemia is that the slope of depolarization leading up to the action potential becomes very steep. So steep that it limits the time between the RR interval. So in a sense, the heart goes into a seizure. The whole idea of giving calcium is to abruptly raise the threshold for the action potential so that the very steep depolarization curve related to the hyperkalemia can be dealt with medically. All right? So that's the reason we give a large bolus of calcium first, and then we start on the transcellular distribution planning and the elimination planning. What have people used for chronic management? Well, the most popular is K-Exolate. It's been around since 1958. Until this past year, there was never a published study on its efficacy. Not one. Just this past year, there is a published study in 33 patients. That's pretty good for nearly 60 years of experience. But nonetheless, this is a potassium for sodium exchange. And we've heard a little bit about sodium already this morning and why it may not be a great idea in our dialysis patients, and yet there are dialysis patients who receive chronic K-Exolate therapy, and in France, about 40% of patients do, believe it or not. I don't know what it is about the French. It's probably safer to give your patients red wine. Well, maybe not. But I think it's important to realize that K-oxalate is not a chronic long-term solution because it's not very palatable. I always like to preach the golden rule to the house staff. Do unto others as you would to do unto yourself. So I always insist the house staff try it first before they ask the patient to taste it. It's like liquefying sawdust in water. That's what its consistency is like. But I think more importantly, the real issue with K-oxalate is related to the colonic injury that can occur. It is real. It is underreported. It can be lethal. And it's for that reason I prefer not to use this in any of my patients. So if one looks at the long-term strategies that we have, you can stop your RAS blockers. You can give them K-oxalate. Sure, you can recommend a low potassium diet, but you can't do that. Most of what we were served today for lunch was healthy. It has lots of potassium. And I think more importantly, we don't have any data yet that lower dietary potassium really solves the problem of hyperkalemia in chronic kidney disease patients, believe it or not. Yet we pay dietitians to do it all the time, don't we? Yep. I love the review. Cam Calentar wrote a very nice review, about a year or so ago about how we recommend diet for our people with CKD and dialysis. It's all basically, they can eat nothing but bad food. Because all the good food is the food that contains the potassium and a phosphate, basically. The very things we tend to limit in them. Other strategies for controlling potassium has raised the hair on the back of my neck. I have faculty that have actually given human beings fludrocortisone to help lower potassium. Think about it. The very substance that we know is a cardiac and vascular toxin actually being given proactively to human beings. Again, not an advisable thing. If anything, you should be blocking aldosterone, not giving it to people unless, of course, they have adrenal insufficiency. So again, not a desirable strategy. The other option are fixed-dose combinations of sodium bicarbonate with various loop diuretics. Again, it's going to contain a sodium load, but hopefully increasing sodium with the loop diuretic will facilitate kaliuresis in the distal tubule. But again, it can be problematic in people with heart failure and advanced chronic kidney disease. Which leads me to really the unmet need, excuse me, and why there are two newer therapies that are being developed. The first of which is available already on the market. It's called Potassium. It's also known as Veltassa, but I don't like that name. I like Potassium better. This is actually a polymer that was designed to exchange calcium for potassium. So there is no sodium involved, which obviously for people with heart failure and chronic kidney disease is a good strategy. It is odorless, tasteless, and in a very small volume of water can be consumed. And basically it serves as a potassium sink in the colon. Can be taken once a day. The pivotal phase 3 study that led to its approval, I was fortunate enough to be the PI of. I'll present that data here. It was actually designed in conjunction with the FDA because there were two parts to the study. Part A, where CKD patients with potassium levels above 5 or above 5.5, you can see they were broken down into two groups of either mild or moderate to severe. All were treated with the polymer, and then after a period of 4 weeks, they were randomized, if they were in the higher potassium group, to either stay on the drug or go to placebo, and then followed for an additional 8 weeks. In a nutshell, this is what we saw. As you can see, the average potassium level was in the low 5s in the mild group, mid-high fives in the more moderate to severe group, and almost everybody ended up at about 4.5. And then if you take them off the drug, you can see the potassium goes back up. It's also interesting to see that it takes a week or two for the potassium to go back up. It's not right away. It's a slow process. So, a lot of us are in the habit of checking a K maybe in a week or so. That may not be soon enough to get the full picture of how things are going to change. What you can see here is that the majority of the people had substantially reduced GFRs that we studied, typically, as you can see here, in the 20s and 30s. The other area of note is that they were in their early 60s. A large percentage of them had either diabetes or congestive heart failure. And as you can see here, a lot of them were on RAS inhibitors, about half, and the majority of them were also on some form of diuretic therapy. As you can see here, the average reduction in potassium is about 1 milliequivalent per liter. But you get more reduction the higher you start. So if you start at 6, you'll end up at 4.5. If you start at 5, you'll end up at 4.5. And of course, the interesting question is, in this study, we looked at people all on RAS inhibitors. And of course, you wonder about, well, how can I start somebody on a RAS inhibitor? Well, again, we have data showing if you start people on RAS inhibitors, the potassium goes up about 0.4 to 0.6. So you can almost predict that you'll be moving into a range of concern, which is why we tend not to prescribe RAS inhibitors in these patients. The good news is, in this study, people tolerated the drug very well. There were very, very few dropouts. Most common side effects were low and typically related to the GI tract, either constipation or diarrhea in some. In the withdrawal part, though, I think it's important to note that if people remained on the polymer, the potassium remained stable. If they went off the polymer, the potassium went up, and you can see that here. And the time to first potassium over 5.5 was quite a bit different compared to remaining on the polymer versus going on to placebo. And this is really what the FDA wanted to see to prove beyond reasonable doubt that the drug was having an effect in maintaining control of serum potassium. Now, we have done some post hoc analyses of this particular study. This is one that we just published in KI last month, where we looked at the relationship between serum potassium change and serum aldosterone. And you can see that almost superimposably, as the polymer binds and removes serum potassium, there is a reduction in serum aldosterone levels. Now again, that's actually potentially a good thing. And again, realize that this is in the setting of potassium for calcium exchange. Again, one does not know whether you'd see the same thing if it were a potassium for sodium exchange, for example, as with K-exolate. We also noticed that blood pressure consistently declined with the use of the polymer. Now again, is this related to an intercurrent reduction in serum aldosterone levels, or might the polymer also be binding to sodium? We just don't know at this point. More studies need to be done, but it's certainly worth exploring. We also did a 52-week study, and again, to examine whether or not the polymer A was well tolerated for a year, and B, whether the potassium remained controlled. Obviously, the figure is worth 1,000 words. The potassium went down, and it did remain controlled. We also saw in this study, in a secondary analysis, that the blood pressure also went down. Not a little bit, a lot. Weird. Now you might say, well, maybe that's because people could stay on their drugs. Well, we don't know. I just don't know. It obviously is the second study where we see a very similar observation of blood pressure reduction. It makes you wonder again, what's the mechanism? Is it aldosterone? Is the polymer binding sodium as well? We just don't know. But again, most of us would not complain about more blood pressure reduction in our patients with chronic kidney disease. And this is also the diastolic. And again, these are real reductions, not subtle. Adverse events over the course of a year. Again, I don't have placebo control, but again, one can see from a percentage standpoint that it's all quite low. Some of you may say, well, the blood pressure may go up in some. This is random fluctuation. Likewise, kidney disease can go up and down. These are people with advanced disease. ZS9 is another new strategy. It's not yet approved by the FDA. It may be very soon. They had some manufacturing issues, I suspect, which delayed its approval for this particular year. It is a unique trapping mechanism incorporating zirconium, and it's very potent for binding to and removing potassium. Like K-oxalate, though, it does exchange sodium for the potassium. There have been a couple of good studies to look at its overall efficacy. This was the first one that came out. You can see 237 people were studied for a period of 4 weeks in a variety of different doses. More of a dose-finding study than anything else. Initially, it was studied 3 times a day. The patiromer, I shared with you earlier, was studied twice a day. But again, it is likely that this will be approved as once a day, the same way the patiromer has been approved for once a day treatment. As you can see here, there was a fair amount of comorbidity in this population of people with CKD. And you can see here the serum potassium levels falling nicely with increasing dose of the ZS9. Again, typically from here, 5.1 down to the middle 4s, very analogous to what we saw with the patiromer. And you can see over a period of 4 weeks that this dose-dependent reduction in potassium is maintained and obviously different than placebo. Adverse events, quite well tolerated. Again, only at the higher dose does one start to see some pedal edema, which again could be related to, again, the higher amount of sodium exposure with it. It's also been studied in another large clinical study, as you can see here, to look at its use acutely and then subacutely. And here is the clinical trial design, looking at a variety of different doses, and then people randomized to either stay on the drug or come off, very analogous to the patiromer study that I shared with you earlier. And you can see here again that the effect of the drug is quite real. The impact of this drug in reducing potassium levels is seen within 1 to 2 hours. It's a little bit quicker than the patiromer, which is seen in 4 to 7 hours, which suggests that it may be working more proximally in the colon or small intestine compared to the patiromer, which tends to work more in the colon. But clearly, one can see that there is indeed a dose-dependent reduction in serum potassium, which then disappears once the patient is switched to placebo, as shown here. a very nice separation, again indicating the persistent effect of the drug and how serum potassium levels change over time once the patient is taken off and switched to placebo. Adverse events, again, quite well tolerated, like the polymer patiromer as well. Again, I think this is really what separates these two newer therapies from K-exolate, is that they are both very well studied with regard to safety and efficacy. The only thing we're still missing now with the ZS studies is that they are in the process of a one-year study to look at its long-term use. So I think it's important to note that both of these newer therapies will provide, I think, an important new avenue for chronic therapy. As I've mentioned, they are both well studied, well tolerated. There are some mechanistic differences. The patiromer exchanging for calcium rather than sodium. Maybe that explains the change in blood pressure that was seen associated with it. They can both be taken once a day. There were some initial concerns with the patiromer that it needed to be separated by at least 6 hours from other medicines. There is some newer data soon to be published to suggest that that is not necessary, save for the use with drugs like quinolones. I think in the meantime, though, I would adhere to what's in the FDA package insert, which suggests that it be separated from other drugs by as long as possible, and preferably even up to 6 hours. Likewise, we'll need similar data with the ZS to make sure that there may be no binding issues which could interfere with other therapies. I think the biggest problem we still face in the field of nephrology is that hyperkalemia is a chronic cause of RAS inhibitor misuse, disuse, and cessation. It is particularly important and beneficial in our people with chronic kidney disease and heart failure. I think these newer therapies will provide an important new opportunity for us for chronic management. They may actually allow our expansion of use of RAS blockade and even MR blockade in our patients, which I think could be an exciting and important new opportunity for us in clinical practice. I think also, too, it raises questions about our use of older therapies, such as K-exolate, which is not as well studied and is potentially harmful. I want to reiterate that fludrocortisone is not a treatment for chronic hyperkalemia, as it may obviously have very disastrous effects on the vasculature of the individual patients who receive it, unless, of course, they have adrenal insufficiency. And certainly it may obviate the need for giving people sodium bicarbonate, unless, of course, they have acidosis, and loop diuretics as a strategy to control hyperkalemia. Likely this is going to be an area of future interest, especially in dialysis patients who have not been well studied yet with these drugs. And I know many of you are interested in that. I would say the following. I have started to use it in dialysis patients, but what I do is I substitute the patiromer for the phosphate binder at the lunch period. And the reason I say that is we don't know yet about potential interactions with phosphate binders. And also, interestingly, small studies suggest that the potassium for calcium exchange actually appears to reduce serum phosphorus levels a little bit in dialysis patients. And that obviously could be helpful as well. We also need to do more work in the kidney transplant recipient. Many of these people have chronic hyperkalemia due to their calcineurin inhibitors, even absent the use of RAS inhibitors. And of course, we need more data on potential use, potential drug binding and or interactions, which needs to be well defined. So I will finish there. I would be more than glad to entertain any comments or questions. I appreciate very much your attention.